Uit. Nog niet. Ik ben aan. Ja. Ik ben niet Hester.
Ja, ik ben ook aan. So good morning and welcome to this session on value-based healthcare, financial sustainability, an unfulfilled promise. That's the question we would like to answer with you this morning. So value-based healthcare is a very popular concept, which is also apparent from the fact that you are all here. And we were actually the first session, I think, that was sold out. So that also says something about the popularity of the concept, I think. High expectations, it would improve healthcare quality and save costs. So it's hard to be against it. And I think a lot of actors in the healthcare field are also drawn to this concept. Healthcare organizations are working with it, but also insurers, the Healthcare Institute, the Ministry of Health. So in all these places, value-based healthcare is an important concept and the expectations are high. And I remember a symposium. It was for the celebration of the inaugural lecture of Diana Delnoij, who is also here. And one of the conclusions there was, well, it's good that everybody's happy with it and so excited about it, but we don't talk about an essential part, and that is the costs. And that is what we are going to do today. I am Hester van de Bovenkamp. I work at the Healthcare Governance Department of Erasmus School of Health Policy and Management. And what I also like about value-based healthcare is that it's also a subject that we do a lot of research on from different disciplines. So I think it's also something that shows actually the added value of our school, so that we can see these different dimensions of value-based healthcare, and that's what we also want to put forward today. So we have 4 presentations. We will start off with and actually showing these different aspects of value-based healthcare in relation to the costs. So Gijs Steinmann, a PhD student at my department, will be talking about, well, there's a lot of talk about value-based healthcare, but where are the costs actually? Anne Stiggelbout will then talk about the role of patients in value-based healthcare, and are they the ones then who are going to save costs? Frank Eijkenaar is talking about the role of healthcare insurers and different payment models in relation to value-based healthcare. And Maureen Rutten will be talking about also, well, what can value-based healthcare, can it add something in discussions on reimbursement, and how does it compare to cost-effectiveness analysis? So they kick off today with short presentations. Then we have a very nice panel as well who are going to respond to these presentations. But then we also want to discuss these subjects with you. So also feel free to participate in the discussion after these presentations. So I'm very much looking forward to it, and I'm also considering the time, we'll stop talking now and give the floor to Gijs. So can I invite you?
Okay, yeah.
You are also on, yeah.
Okay. Hello, everybody. Welcome. Nice to see you all here. So my name is Gijs Steinmann. I was already briefly introduced. I think most of you, or some of you, will know me. I do see some unfamiliar faces. So I'm nearing the end stages of my PhD research, which is actually on value-based healthcare in the Netherlands. And I used to sometimes refer to the topic of my research as the implementation of value-based healthcare. But really, implementation doesn't really capture what's really going on, as I guess is often the case. One way in which this is shown concerns I think, what is happening to costs, or maybe what is not happening to costs. So I think most of you will know that within value-based healthcare, cost is a huge thing. It's the denominator of the value equation, where value equals the health outcomes that matter to patients, divided by the costs for achieving those outcomes. A big part, or perhaps the most crucial claim made by Michael Porter and other hardline value-based healthcare proponents, is that optimizing that equation should become the overarching goal for healthcare systems, the overarching goal for all stakeholders. And all stakeholders in healthcare are envisioned to also have a vested interest in optimizing that equation by continuing striving for the best possible health outcomes, and doing so at the highest cost efficiency, at the lowest possible cost. Accordingly, if we would make that the overarching goal, then value-based healthcare could indeed also contribute to the financial sustainability of the system. Porter's theory envisions three, I would say, basic mechanisms by which cost efficiency or optimizing cost efficiency could be achieved and should be pursued, according to value-based healthcare. And all have their preconditions and requirements. So first, if you want to optimize that equation, then you should start measuring not only health outcomes, but also the costs of the cost for achieving those outcomes. An important part, something that's sometimes glossed over, an important part of value-based healthcare is the idea that value should not be measured, analyzed, and understood at the level as broad as hospitals or other broad healthcare organizations, and also it's not created and should not be measured at a level as narrow as individual procedures, such as surgical interventions. Instead, value should be understood and analyzed and measured at the level of medical conditions or otherwise similar patient groups, and over full cycles of care. Full cycles of care for a patient with breast cancer, for instance. So next to measuring a predefined set of outcomes that matter to patients, providers should also start measuring the costs of their care cycles. And based on those measurements, you can tweak and try to experiment and try to optimize efficiency. The second mechanism by which cost efficiency could be pursued in line with value-based healthcare is by radically transforming the way we pay for our healthcare from a system in which is now prevailing, I would say, fee-for-service arrangements, which have a built-in incentive to provide a lot of services, to increase the volume of care, shifting to bundled payments for a full cycle of care for a particular medical condition, which would then, at least in theory, incentivize efficiency. Thirdly, and very related to the idea of incentives, we should enable, according to value-based healthcare, according to Porter, enable providers to compete, but compete on the level of medical conditions and for more patients. The idea being that in a system of value-based competition, those providers who show relatively good outcomes or similar outcomes but achieve those more efficiently, those should be rewarded with more patients. In practice, though, and I'm going to exaggerate a little bit here, a bit of a black and white picture. In practice, at least in the Netherlands, and I suppose in other countries as well, none of this is really happening. None of this is really happening on a truly significant scale. What you see in practice instead is that certainly among providers, but other parties as well, when it comes to value-based healthcare initiative, there is this massive emphasis on outcomes relative to costs. Costs are secondary, and I really think secondary doesn't capture the divide of attention between the two. So what you see, for instance, also that the responsibility for measuring, let alone measuring costs on the level of medical conditions, that responsibility is sort of shifted, avoided. You see the government has a program, the Ministry of Health has a program based on value-based healthcare, but measuring costs is not even mentioned. The focus is solely on outcome-based care, they call it. Within provider organizations, what a line of reasoning I've repeatedly run into is that the best way to lower costs is really to optimize outcomes. So there's really no need to focus on measuring costs right now. Also, what I also see happening often is that the responsibility for costs is connected to money, and therefore that's the payers department, that's the role of insurers. But then if you look at what insurers do in practice, sure, there are some Dutch health insurers who are experimenting with alternative payment models and bundled payments as well. But really, those pilots, those projects are just a minor fraction of a system where structurally healthcare isn't really purchased critically on the level of medical conditions, but instead hospitals particularly are budgeted annually. This is the total amount of money you can charge me for next year. There's no critical purchasing based on outcome indicators or efficiency measures, and even prices don't function. The DBCs don't really function as prices. Also, providers surely they compete for patients, but they definitely don't compete for patients on the level of medical conditions. And they surely don't compete for patients on the level, on the basis of efficiency. There's just no mechanism in place in our system where if you would be more efficient, you would get more patients. There's no such incentive in place. So, with none of those three mechanisms in place, this, I think, does put some question marks around the idea that value-based healthcare can, in some way, contribute to financial sustainability. Personally, I think, and this relates to my closing statement, if value-based healthcare would somehow contribute to financial sustainability, it would have to be through providers taking on the responsibility for measuring the costs of their care cycles. It is sometimes, I do find it amazing that there is this obsession, you could say, with costs. The costs are rising, but we don't know what it costs to treat a breast cancer patient. We know how much we pay for, but we don't know what it costs. So that is my closing statement, and I think Angelique will then first respond when the panel session opens. Thank you for listening.
Yeah, thank you, Gijs. And we want to do the discussion at the end of all presentations, but if you have some clarifying questions, then we can maybe take some after each one. So I don't know if there is a question for Gijs right now. No? Then I will give the floor to Anne.
Thank you. I'd like to stand a bit up here so as not to block the PowerPoint. I'm standing here, I'm from the section of Health Services Management and Organization, where I started last January, 1 day a week. The other 3 days I work at Leiden University Medical Center. And I do a lot of research on shared decision-making, train doctors, train medical students. And there's been a lot of argument that shared decision-making is going to save healthcare because it's going to reduce costs. And I want to introduce a little bit, maybe all of you know already, but I just wanted to have some background on shared decision-making itself, a bit of the history and why it's so prominent now at the moment. And because it's been there already since the late 60s, particularly in the Netherlands with the ethical decisions around euthanasia, etc. It's always been there, but practice variation was an important impetus in the years 10, and particularly with Minister Schippers, and I'll talk about that later. And now it's value-based healthcare. And I think since value-based healthcare, it started really to boom, like Gijs already said. And there are some effects of shared decision-making, why it's being promoted so much, apart from lowering costs, which we sometimes hear. I'm not going to discuss all of these. The bolder ones have more, written in bold, have more evidence than the other ones. Hard here is, thinking of Trish Greenhalgh's talk, it's not so good to do evidence-based medicine, RCTs on shared decision-making. You can do RCTs on decision aid implementation, but not so much on shared decision-making itself. It's hard to randomize patients within a doctor to yes or no shared decision-making. So Minister Schippers, she wrote a letter to Parliament. This was already, if I have a pointer, yeah, laser pointer. October 2015 on shared decision making, a letter to Parliament that really got a lot of attention. She didn't say it was going to be cost saving, but I think she hoped it would be. And she said we really should promote shared decision making. And that was because of the practice variation discussions. And I thought I had another picture. Jack Wenberg in the US showed already that in states with many urologists, many more prostates were removed than in other states, saying it's not that those men, they don't care so much about their prostates than men in other states. It's fee-for-service payment, and that's why there's more prostates removed in those states. And we see the same kinds of variation in the Netherlands, showing that there might be over-treatment, because why would it be better in situations where there's more treatment? And so this was the plea. Clinicians are prone to over-treatment. Patients choose more conservatively. That was because the decision aids showed that. I'll come to that later. So we'll do shared decision-making. And the case for lower costs mostly comes from all the research on decision aids. I already mentioned that. This has been really truly evidence-based medicine, Cochrane reviews, 133 RCTs of yes, no, a decision aid, a tool to help patients make decisions. And patients were shown to be more conservative than patients who used the decision aid than patients who didn't. So fewer surgeries and fewer tests. So that made a strong case for shared decision making. Then there was another EBM paradigm paper looking at RCTs or at economic analysis from a very EBM type perspective, saying there's not enough evidence. So this really follows Trish's talk nicely, I think. This was in BMJ Open. So the evidence is not really strong EBM wise. Another type of evidence that's totally not strong, that I would like to put forward here, is the case of Bernhoven. The Dutch may know this, people who read the newspaper. Bernhoven is now in financial troubles, but we think not, many people think it's not because of shared decision making. It was a best practice for some of the healthcare insurers, and this fits nicely with Gijs's. Here was an impetus to do it differently. They didn't get their yearly budget based on the DBCs, based on all the actions they did, but they kept their budget and they were motivated to talk to patients, to implement decision aids, to perform shared decision making, and they were promised they would keep their budgets for 5 years, and indeed we saw a reduced budget from this. And it's totally not evidence-based medicine here, but there is a strong indication that if you have more time to talk to patients, you're really financially incentivized to do so. It might help to have more shared decision making and have reduced production. Of course, all these RCTs showing fewer herniated disc surgery, fewer prostate tests, fewer knee replacements, hip replacements. There might also be cases where you have more. My hunch is that the decision aids are developed in situations where the doctors are willing to implement them, so they're willing to do fewer surgery. But I think a major thing is we need to teach the public that more is not always better, because that's a major driver of healthcare, that more is better, more treatment, more chemotherapy, more immunotherapy, etc., etc. Thank you.
Thank you. Are there questions right now? Still no? Then Frank.
Working. Test, yes. So, good morning, everyone. So my name is Frank Eijkenaar, and I'm an associate professor at the Department of Health Systems and Insurance of this school. And I would like to talk about the question, the extent to which reform of payment models of healthcare providers have been able to contribute to the mitigation or limiting of spending growth in healthcare systems. And of course, we all know that spending growth has a variety of different reasons. Unfortunately, many of those reasons are not addressable or not readily addressable. But some of these drivers or reasons are, I think, and one of those are the incentives that underlie the efficiencies that are still unfortunately present in our healthcare systems. And these incentives are increasing demand, they limit value-conscious behavior, and also discourage innovations from adding value to the system. So what I will be doing is talk about the financial incentives that are embedded in the methods used to pay for healthcare providers, and more specifically, what reform of those incentives has brought us so far. So a few words about the relevance for doing that, so the relevance of financial incentives in a value-based healthcare context. And I think there's a couple of points to mention here. First of all, well, it's a no-brainer. Financial incentives do influence behavior. That's in other sectors, but definitely also in healthcare, and often also in the expected direction. Second point, and this is a related point, is that current payment models, the current ways in which we pay our healthcare providers, they tend to emphasize volume of care instead of value of care. This was mentioned already a couple of times. So the fee-for-service payment models, which are still predominant models of paying healthcare providers, they simply emphasize volume instead of value. I think that is a fact that most people would be in agreement with. And finally, in my mind, value-based healthcare is all about aligning interests and aligning the interests of all actors involved with that common goal, that overarching goal of maximizing value of care. And well, that makes it clear to me that in the financial incentive that is about aligning interests, that it's relevant to look at that as well. And this is also acknowledged in value-based healthcare theory, right? So this is a picture from a paper by Porter and Lee in the Harvard Business Review, depicting the broad strategic agenda for moving towards a value-based system. And as you can see, payment reform has a distinct place within that framework, suggesting that in addition to measuring outcomes, in addition to measuring costs and organizing care differently, we should also think about paying healthcare providers in different ways. So I guess my message with this slide is that the bottom line, it would simply not make sense to pursue value-based healthcare while at the same time maintaining payment models that actually provide disincentives for that. And as a response, it's not that surprising that worldwide we see a lot of experimentation going on with all kinds of alternative payment models or value-based payment models. And I like always pictures, frameworks, taxonomies that provide a bit of order in that chaos. And I really like this one. It's a very simple one. So as you can see, 4 categories of alternative payment models, and this is, by the way, from the HCP LAN, the Healthcare Payment Learning and Action Network in the US. And categories 2, 3, and 4 actually try to move away from that fee-for-service status quo, which is category 1. So very briefly, category 2 alternative payment models are essentially pay-for-performance payment models, providing explicit financial incentives on top of that fee-for-service status quo, usually linked to quality of care. Category 3 models are shared savings and shared losses models, so providers continue to be paid on a fee-for-service basis, but may share in losses or savings relative to a predetermined spending target or spending benchmark. And finally, we have category 4 payments or payment models, which actually provide prospective payments to healthcare providers on a condition level, called bundle payments, and Gijs already mentioned them, or on a broader level of populations, called population-based payments or global payments. That's also a common term. And I think especially category 3 and category 4 models, they aim to shift financial accountability from the payer towards the healthcare provider in order to introduce incentives to work towards value, including cost consciousness. And I think the theory of all of this, of paying for healthcare value, is quite strong. So here's a couple of papers that have written about it, and although these papers also warn about, well, it's complex, the design and implementation is not so easy to do, I think the common sentiment, the overall sentiment of this work is that it could or perhaps should work if we do it right. And that's the thing, right? How to do it right. So it can work in theory, and then of course the question is, has it worked in practice? And I think this is a really nice illustrative paper, or rather sort of blog in the New York Times by Austin Frecht, and he is a renowned health economist writing a lot about this topic. And he summarizes the lessons of almost 10 years of value-based payment reforms in the US, specifically in the context of the Patient Protection and Affordable Care Act, also known as Obamacare. And the message is quite clear, which is, despite some promising signs for some payment models, especially those more on the right of this framework that I showed you before, the evidence is simply not that convincing. And he frames it like the successes are more likely to be singles rather than home runs, with even the most successful models only achieving a couple of percentage points reductions in savings, or reductions in spending growth, or savings accrued relative to a spending target. Well, this is a blog in a newspaper. How about the real scientific evidence? Well, it's there. So a couple of systematic reviews on pay for performance, bundled payment, global payment, and indeed for pay for performance, it's not very convincing. Many studies have been performed. Few of them found positive effects on quality of care, let alone costs and health outcomes in the longer term. And as I said before, bundled payment models, global payment models, more positive signs, but the successes are more likely to be singles rather than home runs. And that brings me to my closing statement, which is that I think paying for healthcare value is a very popular slogan, and it probably will remain to be so for the near future. But we're still largely in the dark regarding the question, how should we do so? And I think more generally, we still know very little about what different types of value-based payment can really achieve, and more importantly, how, when, and under which conditions. And I think moving forward, it's very important to try to open that black box and start answering the questions of why and how. And in that respect, I think it's nice to mention that at this school, together with several external partners, I see Jeroen smiling, yeah, he's part of the consortium, we have initiated several research projects in which we have deliberately chosen to adopt a mixed methods research design in which we systematically evaluate ongoing payment reform initiatives in the Netherlands. So in addition to quantitatively evaluate the impact on spending, but also on quality, we also have this qualitative realist evaluation approach in which we want to answer questions of why, how, and under which conditions. And we have a dedicated LinkedIn webpage, so if you're interested, have a look. And with that, I will stop. Thank you.
Yeah, thank you, Frank. Questions? Still no. Then we go to the final presentation. Maureen, the floor is yours.
It's on. Good morning. Good to see you. My name is Maureen Rutten, and head of the HTA department, the Health Technology department of our school. I would like to talk about the comparison between cost-effectiveness analysis and value-based healthcare. In cost-effectiveness analysis, we adopt an incremental approach in which we compare the difference in costs between interventions, divide that by the difference in effects to calculate an incremental cost-effectiveness analysis, an incremental cost-effectiveness ratio, I should say. And we compare that ratio to the lambda, which is the value of the benefits that we currently generate with the healthcare services already in the system. And if we think the ICER is below the threshold value, then our conclusion is that a certain healthcare intervention or service or innovation or technology is indeed found to be cost effective. So that's our common cost effectiveness approach, in which we aim to maximize the health gains by giving priority to interventions with the lowest cost per unit of health benefits, so the lowest costs per QALY. So it's more or less a one-time single assessment, so looking at static efficiency, usually to inform national level decision-making on reimbursement decisions with respect to our in or excluding interventions in our basic benefit package. So when we compare our cost-effectiveness analysis to value-based healthcare, then in value-based healthcare we do not adopt an incremental approach, but we try to maximize patient-relevant outcomes per euro spent. So we concentrate on patient-relevant outcomes as compared to usually quality-adjusted life years in cost-effectiveness analysis. So value-based healthcare is sort of a continuous process in trying to optimize the treatment pathways in order to improve patient-relevant outcomes, usually at local level in relation to costs. So both approaches try to define value, but in different ways. In cost-effectiveness analysis, we focus on a QALY, which is a generic health outcome combining improvements in life expectancy with improvements in quality of life. And in cost-effectiveness research, we have well-developed methodologies to not only estimate value, but also to calculate costs. You know, in the Netherlands, we have guidelines for doing cost calculations, we have reference prices, we have developed methods and questionnaires, for example, to measure informal care costs or costs in life years gained or productivity costs. So cost-effectiveness analysis has a strong scientific and theoretical basis in welfare economics. But we do admit at the same time that also a quality-adjusted life year may not include all relevant elements of benefit that are generated by some interventions. Think, for example, of the care sector, where the aim of interventions may not always be to improve health, but perhaps maintaining well-being, just as an example. Compared to cost-effectiveness research, value-based healthcare focuses on patient-centered and disease-specific outcomes, including those that go beyond health and longevity. And there's a strong emphasis on shared decision-making in designing the process of care delivery. And it seems that value-based healthcare aspires to measure, compare, and improve all aspects of healthcare at once, but without providing sufficiently clear evidence or guidance on how to do so, because there are no established methods to measure value, but certainly not how to do the cost estimations. And when we talk about defining value and including different types of outcomes in the analysis, I see a lot of similarity with the discussion that we are having in the field of health technology assessment and in health economics about the value frameworks. And here you see the value flower that was proposed by an ISPOR special task force working on these value frameworks. And in green and in turquoise, you see types of outcomes and values that we usually include in cost-effectiveness analysis, especially in the Netherlands, where we adopt a societal approach. And in blue, you see additional elements of value that some people argue are not included in cost-effectiveness analysis and cost-utility analysis. For example, things like the value of hope, the value of information, and other types of values that are not even on this slide, the value of a complete cure, or the value of knowing. So many different elements of value may we may recommend that they exist and are not or not entirely included in QALYs. There's a lot of debate ongoing on this because a number of concerns can be raised as well. Probably there is some double counting between these additional elements of value and quality adjusted life here. Some elements might be included, like issues related to severity of disease, for example. And also, we do not have currently the right methods to measure these additional elements of value. Another issue is that we place or overemphasize positive elements of value without looking at the negative elements of value. We talk about the value of hope. For example, the hope that you are among the responders of a very effective treatment to which a large proportion of people do not respond. But then again, there is also the other side, the dashed hope, when it proves out that you are not among the responders. So we shouldn't overemphasize only the positive sides, but also look at the negative sides. So, as I said, yeah, probably these elements of value do exist. And as individuals, individual patients might be willing to pay for these additional elements of value as well. But that does not automatically mean that we as society should also pay for additional elements of value out of public sources. That's a different question. And especially not if we pay for additional elements of value at the expense of interventions that provide more health gain. And to illustrate that point, I just want to show this illustrative numerical example that we made in Horizon 2020 project ESHPM to make our point. Because what we usually do in cost-effectiveness analysis is compare two treatments, A and B. And in my stylistic example, treatment B generates more QALYs. And what we do is calculate then the net monetary benefit of these treatments. In this example, assuming $50,000 as a threshold. So we simply calculate the net monetary benefits as 2 times 50,000 is 100,000 minus the cost of these interventions, which are equal, 80,000, gives 20,000. When we do this for B, 2.5 times 50,000 minus 80,000 gives 45,000 net monetary benefit. And then in our usual framework, we would adopt or recommend treatment B to be reimbursed because it has a higher net monetary benefit. Now let's assume that we would include an additional element of value. I called it value of hope, but we call it differently. We may call it differently as well. Value of a complete cure, for example, and assign that also a numerical value. Then, in this case, treatment A that generates more hope, probably because it's a very effective intervention to which only a small proportion of patient responds with great response, then if we would repeat the calculation, we would do 2 times the threshold value, 2 times 50,000 minus 80,000 plus the value of that additional element of value, which would generate then 50,000 in terms of net monetary benefit. And in this case, we would adopt treatment A instead of treatment B. Although treatment B generates more quality-adjusted life years. So this table is just made to illustrate that if we start including additional elements of value that go beyond health, that might be at the expense of interventions that improve length or quality of life and generate more health gains. And very few people are aware of this trade-off. So my concluding slide, and that's my personal opinion, I think that cost-effectiveness analysis and value-based healthcare can be complementary. Cost-effectiveness analysis should be used for national level decision-making on public reimbursement, whereas value-based healthcare can be used for local level or institutional level decision-making on the optimal or preferred way of delivering an intervention that was proven to be cost-effective, or on prioritizing local treatment investments, treatment options. And for that, we could, for example, use multi-criteria decision analysis, in which we measure the performance of interventions on a wide range of outcomes, health outcomes, but also other elements of value. And we might even weigh these outcomes to calculate overall value scores. So I think both of these approaches have their place and can be complementary. And I think value-based healthcare has a lot to learn from all the methods and instruments that have been developed for measuring costs in the health economic and HDA area of cost-effectiveness research. Thank you.
Yeah, thank you very much. And I would like to invite the speakers now to sit at the front, and also the people in the panel. So Angelique Weel is also joining us. She's a professor of evidence-based patient value creation, but also working with value-based healthcare in the hospital. Daphne Voormolen. She works at our health economics department as a postdoc researcher, actually measuring well-being, but also active as a patient representative. So we also invited her to talk about the issues we discussed today from a patient perspective. Diana Delnoij, she's also a professor of healthcare governance, but also working at the Healthcare Institute. So I think she can also nicely relate to the story of Maureen. And Jeroen Struijs, assistant professor at Leiden University, and also very much active in different payment models and the role of insurers. So if you could join us at the front.
Lekker dit eigenlijk, hè?
So it looks nice and cozy.
Yeah, a bit too cozy.
And we asked the panelists to respond to the different presentations, and then we also would like you, of course, to take up the discussion. And I think, well, what connects these different presentations, well, is, well, that the picture isn't maybe as positive as the value-based healthcare concept is often depicted in discussions, because we don't know, still don't know a lot, or it is very difficult to put into practice. And also the question is, well, who has actually the responsibility for focusing on this cost aspect of value-based healthcare, I think. And I think a number of conclusions of the different presentations relate to that issue. And Gijs ended his presentation with stating that providers should carry this responsibility, making their costs transparent and organizing their care differently. And Angelique, can I ask you to respond to that first, also from your own experience? And I think there's should be another. I will look at the. Oh, you have one. Yeah, great.
Yeah, I think this one is also working.
Okay. Yeah, but then we can use that for people in the room.
Perfect.
Yeah.
Well, first of all, I would like to thank the presenters for nice presentations about the value-based healthcare aspect, and especially on the denominator, because I agree that we miss a little bit of information on the denominator. But I first want to focus on what we really want to, we really want to have value, and the value is outcomes that matter for patients. So I think that's the first priority, and that's also why the national program, the outcome of the uitkomsgerichte zorg in the Netherlands, focused on the outcomes first. And especially for doctors like me, a medical specialist, the outcomes that we want to measure is also different. It's about outcomes that measure to patients. And we, and especially in the evidence-based medicine, we are all trained to look at outcomes, clinical outcomes. So I think that's why we don't see the cost yet. But the research on value-based healthcare, and especially on cost, is there. And I think Maura Leusker, the PhD student from Kees Ahaus, she already showed in a very nice systematic review that there is more evidence on cost within value-based healthcare than the evidence on PROMs. So I don't agree that the costs are not there yet. They are there, but we have to show them to the public and to the audience here also, I think. So that's my first response on your statement. And the second one is that you say that the providers are responsible and it's their care cycle. Well, I disagree. It's not a responsibility of the providers of care to show the care cycle. I think it's the responsibility of every stakeholder, including the patients, who are responsible to show outcome and cost. So we really have to do a lot of work, I think, next couple of years. And the costs are not only related to the interventions, and especially the doctors are trained to look at interventions which are most of the times have influence on the short-term outcomes, but we have to look at the outcomes on the whole patient journey. So it already starts with prevention. Mm-hmm. I think
and
much more work.
More complex, of course.
Much more
measure.
complex also. Yeah.
But you're saying, well, it's very much a collaborative effort, actually, right? So it's not just pointing to one actor in the field. Yeah,
and I think we already learned with Lean and Six Sigma, if you put it to the providers, the doctors or the medical specialists are not included, and the patients are not included also. So I think then we are not coming further on.
Yeah, okay. And maybe we can already go to Daphne, because I think your stories are, you already connect to this patient perspective, right? And you're saying, well, it's also a responsibility of patients. And Anna, you said in your conclusion, well, we should also educate the public and patients to, well, think about the costs, actually more in terms of also value, right? Oh, I'm... I'm pushed here,
Not just about the costs,
but
also about the harms
in the combination
of overtreatment.
in combination with the value, right? Yeah. And I was wondering what you think about this. And
yeah, it's probably good to start with a little bit background about my story to give people a little bit of insight. So about a year ago, I was diagnosed with cervical cancer, but it actually took me a long time to convince the medical world there was something wrong with me. So I hit a lot of closed doors and kept pushing back. And because my background is also, I'm a top sport athlete, so I know my body better than anyone. And I just felt and knew there was something wrong with me. So I fought the medical world for quite some time till I actually received the news, which you kind of don't want to receive. You're right, and you're actually very, very sick. And at that point, I started hitting more closed doors even, because I'm young. I have a wish for maybe someday a child. I wanted to continue my top sport career. And yeah, I didn't really feel that shared decision-making in the doctor's room. So I went from hospital to hospital. As a researcher myself, I did a lot of research, didn't sleep, obviously. So I did a lot of PubMed and ended up having very high discussions with the doctors about the actual like evidence-based research that was out there, which is not a lot because cervical cancer is a rare type of cancer. So what I ended up doing is kind of coming up with my own treatment plan. But that was all based on the research I did. I have a lot of medical doctors around me. So yeah, I ended up joining a medical trial at the Dutch National Cancer Institute. There's only been 90 patients in Canada that have been treated this way. And I'm actually patient 2 in all of the Netherlands. But yeah, I would have never joined this medical trial if I listened to the doctors, because there was about 7 doctors before I got to this medical trial who told me that they wanted to cut everything out, which I just didn't agree with. But then in the end, so we got to a very forceful way of shared decision making. I think I got overtreated a ton, which I didn't agree with at any point in time, because I was like, I'm young. So at every point in the hospital, I was giving pills and whatever. And I mean, the person I am, like, characteristically, I always like to go into a discussion with someone about anything. So the nurses, I drove them nuts every single time. I was like, why do I need to take this pill? I mean, it costs money. Like, why do I need to take this? Yeah, it makes you calm. I'm like, I'm as calm as I can be. Like, why is this needed? Right before I got chemotherapy, I went to the pharmacy and I got like a massive bag with pills and everything and medication. And I was like, why do I need this? And it cost me like almost my whole like own risk. And I was like, why do I need this? Yeah, just in case you get nauseous. And then you have this one, and then if this one doesn't work, then you get this one, and then you have that one. And I was like, why don't we wait to see if I get nauseous first, and then I'll come back, and I'll take them. And they were like, no, you should really take it, because if you get nauseous, blah, blah. I ended up not using the bag, and it was a ton of medication given. That cost, obviously, a ton of money. Yeah, so I was like, if they just waited and saw if I actually needed it, yeah, so I can only agree with all that, like, there should be, from a patient perspective, and it's obviously because I'm educated from this school, so I obviously know a little bit more about it. But yeah, I think a lot of things come from protocols and are set ways that if you would talk to the patient, especially like me as an individual, like young, fit, then there's a lot of different ways that we could go about things.
And how would you then respond to the proposition also that the public needs educating? Because from your story, it sounds more like that the professional needed education.
Well, I think that's also because I was probably like an overly educated patient. But yeah, I think that's a very good way, because I said if I wouldn't have educated myself previously the way I did, and now as a patient, I would have been given a lot of things that I didn't need or didn't want in the end. And I wasn't really heard or listened to, which in the end, the doctors have turned around and told me, like, it's good that you pushed back as much as you did, because you wouldn't have... If I would have listened to my GP who told me nothing was wrong with me, I can honestly almost say that I would not be sitting here today, because we would have been too late. So yeah, I think, yes, it's educating the patient, and it's also, which I've been trying to advocate for, educating patients in a way that, yes, the doctor is the one in the white coat, and yes, they've studied for it, but you know yourself as an individual, and you know what your values are and what you want in life. And that's the most important thing that you can bring to the table. So I had massive discussions with doctors who said, I was educated to give you the best treatment and cure you. And I said, but what if the cure is not the highest thing I want to reach? I was like, if I have to give up my child wish, my top sport career, and all that, then I don't know if the cure is the greatest good for me. So I'm willing to take more risk, or I'm willing to take sacrifices in that end. So, and then the doctor was like, yeah, but I am educated to cure you.
Yeah, so then it comes down to this question, what is value actually, right?
Yeah, exactly. Yeah, and that's for every individual, it's different.
Yeah.
Yeah.
Wow, it's a very inspiring story, so thank you. Does anyone want to respond and add to the discussion at this point? No? Not yet? Also, yeah?
As a doctor, you make a lot of assumptions based on your experience. And I think we could learn from our Department of Geriatrics. They use an op tool in the beginning of treatment, and in the op tool you can indicate what your priorities are. So what are your values and what do you want with your treatment? And I think we use that too little. And then we would have a better response from a patient like you as well. Because first you want to get to know your patient. But especially in cancer, you feel there's a hurry, there's stress, that you need to start as early as you can with treatment. That's another stressor. So we take too little time for that. I tend to agree with that.
Yeah, and maybe at both sides, right? Because I also did research into the stories of patients with breast cancer, and then you also see different stories, right? Some people are also very scared and actually want to move fast, and then it's really in the interaction between professionals and patients. Yeah. And this tool, that's a way of helping you to have this discussion, actually.
Yeah. What is worrying you most? Are you afraid of pain or nausea, or is your goal to live as long as possible? How much are you ready to accept some handicaps which will result from treatment? So it's really exploring where this patient is heading. Yep. And you sometimes you see very surprising results which you did not expect, because as doctors, indeed, we are automatically we assume that patients want to live as long as possible, which is true for the vast majority of patients. I mean that's important. When you offer a patient, let's say, chemotherapy with a lot of side effects, and you say it will only add 5% to your 5-year survival rate, almost everybody does that. Almost everybody. People just hang on to their lives. So that is our automatic response to patients with a severe problem.
Mm-hmm. And how do you deal with that as a professional then? Because, Anna was also saying, we should educate the public also about this. Should you also have a different discussion than in the consultation room about these options, or how?
Well, first that, but the second thing is that we have a lot of theories we are hearing today, but we lack a lot of data, because we really don't know what the real end results, the outcomes of certain choices are. We simply don't know. Only by taking all those questionnaires, which we do now in the Erasmus MC, with every visit from every patient, regardless of treatment, I think in a few years we're going to know what certain decisions will give for end results. But at this stage we simply do not know for the most of the diseases we treat. So cost is a problem. We don't know our costs, but we know our outcomes very badly too. As an example, last year in the COVID crisis, we tried to make a prioritization tool for the OR, for the most stringent diseases. And we tried to find in literature the outcomes in terms of survival. We succeeded in finding survival rates. But really to know how many QALYs you add with a surgical treatment, as opposed to not doing anything or treat the patients conservatively simply wasn't there for the vast majority of diseases. So we are quite ignorant, I'm afraid.
Yeah. Okay. Yep. Oh, you're just passing it on. Okay. Okay. Maybe we can move on to the next panelist, Jeroen. I want to ask you to respond also maybe to the other stories, but focusing on the story of Frank.
Yep. Thank you for sharing your story. I suggest in the second workshop you will be at the end of the panelists, because my 3 minutes of reflections are less impressive at the moment, I think. But anyway, having said that, I was asked to reflect on Frank's presentation. Three remarks. First, I think that we need to understand that alternative payment models are not magic bullets in that sense. And I saw your slide regarding, okay, our model's result is disappointing. I doubt that a little bit, like 1, 2, 3% reductions in some of the places, I think is quite impressive. And I think that we also need to reflect on, okay, what do we expect of alternative payment models and what is a model's result? And I think that sometimes what we phrase in the scientific papers as a model's result are actually quite impressive. So I think that we need to tweak a little bit our thoughts, like, okay, what are the ultimate goals of alternative payment models and when do we think it's a success? That was one. The second one is regarding context matters. And we need to understand that alternative payment models, when we implement them in region A and in region B, and it's the same financial incentive, how healthcare providers respond changes dramatically. And I think that we do not get that enough, and also not in our evaluations. And so we are, I think, one of the regions, let's say, I'm evaluating now the bundled payment for maternity care. And it's the same financial incentive, we changed that. And in one region they really go to adopting electronic health records. In the other region they really go to multidisciplinary training. And in this third region they really go to substituting care from secondary to primary care. But we are measuring actually all regions with the same measures. Mm-hmm. And there's some kind of design flaw actually in my own research regarding, okay, what do we look at, and is it actually the right outcome measures we are looking at? So context matters. So that's why we actually started the bundle, the Center of Excellence for Alternative Payment Models in Healthcare, to really understand, like, okay, in which context, via which mechanism, to which outcomes, and what is the mechanism, and should we actually not measure that mechanism? And in what way, I don't know yet, but that's the academic question, I think. So context matters, that's actually number 2. And the third was a little bit general one. It's regarding Gijs' presentation and slide, like, okay, these are the precondition Porter refers to. And the term precondition, I actually I doubt that one. And I think that going back to the bundled payment for diabetes care 10 years ago, or also to others, that alternative payment models can be a flying wheel for a lot of the other things in the strategic agenda of Porter. And in that sense, it's not a precondition, and they are talking about a prerequisite. But when you look to the bundled payment for diabetes care, they all have now an electronic health record adoption. So all the GPs and the dietitians, they all work in the same electronic health record. I don't know, but I'm quite certain that electronic health record adoption wasn't there if the bundled payment for diabetes care wasn't there in the first place. So it might be that it gives them all kinds of local freedom, room for innovations that otherwise was not possible. So, but it's not a precondition in itself. So it's a little bit semantic maybe, but if you really see like a precondition is like a precondition in the sense that it should be there, I think that's not the case. And that was my third. So first, APMs are not a magic bullet in that sense regarding the results. Context matters. And I really like to reflect on what is a precondition, or what is some kind of sequence in which we go to the strategic agenda. That were my 3 minutes less impressive minutes.
But still interesting points, so thank you. And I think it also relates to what value-based healthcare and these different payment models do in practice, right? Which can be also different things, like you're saying, I think in the end, than Porter is describing. So it can also... We now in the maternity care, we see a spending reduction in the experiment, and then it's an assignment from the Ministry of Health, and then we see that in the bundled payment for maternity care, and they really, okay, we see less spending, less growth. Okay, what is it? Are it the C-sections? Are it? No. It's everywhere. There's nothing. It's C-section or the electronic health record. We don't know actually. It's quite difficult to really have that causal mechanism. What is leading to what, and that black box actually. I think that's a very, very important academic question in the next coming 10 years. Yeah. Gijs, maybe you want to respond.
Sure. Sure, yeah. Am I understandable? Yeah. maybe there was a bit of a miscommunication. Then I don't think it's a precondition in the sense that I think what I was trying to phrase is that Porter sets out these mechanisms by which 3 mechanisms by which cost control or optimizing efficiency could be pursued, let's say, and all have their preconditions. So you should change the payment, and then it's change payment for cycles. But actually, I do understand that it is worthy to figure out the mechanism of causation, but that is not the purpose of installing a bundled payment. The purpose of a bundled payment is to incentivize that providers figure out that mechanism to make savings. And if it's one way or the other, that wouldn't really matter if it has an effect of saving expenditures, considering that all other things being equal, outcomes being equal.
Can I comment on that, or maybe ask a question? Because the examples that Jeroen gave, one was the maternity care, the other one the diabetes care, and what I'm not an economist, but if you do bundled payment, to me it seems, unless you do population model 4 in your 3 models, it's still paying for fee for service. But the service is now a bundled service and not just an intervention.
Yes.
So you might get the savings bit better, but in the Netherlands we're not incentivized for savings because we don't get the shared savings, so we're not incentivized to reduce costs. I think that's it's not so much the bundled payment that's doing something, only maybe improving quality. It's also a service that you're going to pay for. So I don't see why that per se would be cost saving.
Can I react on that? I think you're entirely right.
That's my lay question, who knows a little bit about
if we create
healthcare.
bundles, we start paying for bundles, of course.
Yeah.
And that is also what we saw happening when we studied the bundled payment for chronic diseases in primary care. They were put in place, first of all, to improve the integration of care for patients with diabetes, COPD, vascular disease management, and there are indeed indications that it improved the quality of care. But there was also hope that it would reduce total healthcare costs. And the opposite happened, because we investigated with difference in difference analysis what the impact on total cost was, and we saw a total cost increase due to the introduction of the bundled payments. And that was mostly due to patients who had multiple morbidities. They were included in single disease bundled payments and integrated care programs. And during these treatments, probably a lot of unmet need was detected, and these patients were referred to further treatment, which increased healthcare costs instead of reduced total healthcare costs. So you said, Frank, in your presentation, bundled payments can lead to savings if we do it right. And that if is a really big if here. Huh? We have not done it right for the chronic diseases in primary care, apparently. Because we also have to admit there is a certain incentive to refer patients to secondary care who are complex and probably too costly. We don't want them because then the bundle that you get, the fee is not sufficient. And that incentive is still there. So we should do it right, better than we've done now.
Yeah, I think I completely agree with what you say, but a bundled payment is in essence a payment for a specific condition, and indeed the number of people with multiple chronic conditions is increasing, and in essence a bundle is not really suited for people with those types of questions. So I agree, and I wanted to add another black box to what Jeroen was already saying. I agree, we should prioritize to try to open it, and we actually try to do that now with our new research program. But what you also see for each of the models that I presented before is that they tend to be medias agreements between a payer, a purchaser, and an organization, a healthcare organization. And then a key question is, of course, how to translate those incentives to the professionals that do the actual work. And if that's being done at all, we don't know. And if it's done at all, how? And I think that's a key question as well. Yeah.
And also, because you're saying, well, these bundled payments, well, that don't fit people with comorbidity, and we have a lot of patients who have. What does that say for the future of bundled payments then, would you say? If
well, there are solutions. We see now in the Netherlands, in the primary care payment model, that there is this possibility for combined bundles, for example, for diabetes and cardiovascular risk management, and we see that happening as well. But the next logical step would be moving from a bundled approach to a population approach. And well, these are rare internationally, but especially in the Netherlands. Yeah.
Okay. Thank you. Yeah, Angelique. You.
But I think if we are talking about cost and especially on the insurance for the cost, we still need to focus, and that's the first step, what really matters to the patients. And that's where we are now within the value-based healthcare area, and especially the doctors need to learn what is, I think is important for the patient. So which outcomes are we going to pay for? And if we know the outcome, which cost or which patient journey, every single step within the patient journey is related to the costs, and which costs are responsible for that outcome. We don't know that yet, so how can we pay for it already?
Was that a question for me? No.
It's a good question.
I want to make another remark. Actually, I didn't get the question. I was thinking about my next remark, actually.
Sorry.
1 second.
The question is, if we don't know for what outcome we are going to pay for, first we have to see what outcomes matter and which costs are related to that outcome, and then you can go to a bundle payment, a region bundle, or something like that.
Yeah, two things here. This first one, I think that what we try with alternative payment models, I think, is that we try to remove current barriers. Like providers want to do different things differently, but because of the payment model which currently exists, they are not doing it. And I think that one of the elegant aspects of having a bundle is that you get your local freedom in your region. You can organize it because you have that pool of money. You can organize it in the way you think you should do it together. So that's one, and that. For why are we paying for? What is the outcome? I think it differs between regions, and not ultimately. It's about health gain. It's about maybe lowering spending, etc. But within the region, what are the most prominent issues there? They are focusing on totally different things. So I think that we are not looking for some kind of national ID. Okay, this bundle will lead to this or lead to that. I'm repeating myself, but context matters in this sense also. And another one, I actually get a little bit triggered by your question. Okay, what is then the future of bundle payments? I'm not against, I'm not in favor, but I think we again need to realize that what we now call bundle payments, whether that is really related to the concept of bundle payments, sometimes it's totally not there. So there are many design flaws in what we are doing now, and just saying like, okay, bundle payments is not the right way to go, because we have so much design flaws yet. We really need to think way better about designing alternative payment models than we have did before. And in most of the cases, we let it to health insurers together with healthcare providers, and especially the healthcare providers that need to do it, I don't know, in the evening or in the weekend. But I think it's a science on itself. And so there must be way more support for healthcare professionals, and trying not to offend other people, but also health insurers really need to go way more in this direction. Really, what is the theory, and in our contracts are what we call bundle payment. Is it a bundle payment, and how we have designed it? Is it in the way we think the theory says we should do so? Most of the cases, the term polder model was also here. That also happens in our contract, and then they're standing. We have a new I don't know, a global payment for chronic heart failure. I don't know. We have a bundle. At the end, it appears to be a shared savings contract. So creating some kind of common language, some common knowledge about what are we talking about and what are we implementing actually. I think there is quite a role for, I think, public government to support that way more than we do now. Can we help insurers? Can we help providers in designing new alternative payment models? Actually, before we are saying bundle payments is not the right way to go.
Okay. Okay. And yeah,
long answer.
We're going to Diana.
Diana, yeah.
Yeah. I think we have some
Most
time,
patient
Save the best for
panel member ever.
Sorry.
Yeah, thank you. I was asked to reflect on the talk that Maureen gave, and I'm happy to do that. I realize that maybe for the sake of discussion, it would be better if I would completely disagree with what you've said, but actually, I kind of agree. Maybe I should first start by explaining that I am affiliated with the Erasmus School of Health Policy and Management, but my main job is at the National Healthcare Institute in the Netherlands, and that's a public agency, and we use health technology assessment to advise on the content of the benefits package under statutory health insurance. And one of the things that we also try to stimulate is appropriate care. And we define appropriate care as care that is effective and cost-effective, but also care that is being tailored to the needs and preferences of individual patients, and care that is organized and delivered in an efficient way. And much of the work that we do for this advice on the basic benefits package is around decisions about new technologies, mostly drugs. And in that line of work, the ICER, the incremental cost effectiveness ratio, is a vital element of our assessment and our appraisal and the advice we give to the Minister of Health on whether or not a new drug should be included in the basic benefits package. However, if the advice was positive and the new technology is covered under insurance, then for appropriate care to be provided in practice, we as a society have to rely on the decisions that are taken by individual professionals and individual patients in the consultation room, at the bedside, or over the telephone often also. And we want those decisions to be taken not from the perspective of maximizing the professional's income, but we want those decisions to add value to the life of the patient and to society as a whole. And I think there I see the complementary aspect of value-based healthcare. Because value-based healthcare has the promise that it leads to a learning healthcare system in which data are being collected that enable professionals to find out what works for whom, in which order, in which combination, and share that information with the patient in the process of shared decision making, and then take decisions that are right for that patient. And I think that is a really good promise, but it's still a promise, because maybe we don't realize enough how much different that is from the work that we usually do in health technology assessment. It's not about comparing the effectiveness of one drug against a placebo or a different drug in groups of patients where you look at it retrospectively, essentially, but it's about trying to predict for one specific patient what will work in this specific case. And for that, you need measures that are sensitive enough to do that. You need statistical techniques that maybe we don't really have or understand the way we should understand them. So it's a completely different way of working, and so it's also a sort of a social experiment, I guess, not just a technical issue. And I think that this wish to predict what works for whom, given your circumstances and your preferences, that also brings me to something you said, Maureen, about the value of hope. I think you call it the value of hope, but I think of it rather as the cost of uncertainty, because there is often that uncertainty in terms of heterogeneity of effects. We know it works for some patients, but it doesn't for others. But can we predict for whom it will work? And can we also take that information to the preference talk and the option talk with the patient and explain about, well, for someone like you, it might work, but think about not just the cost to society, because that won't matter much to the patient, I think, but think about the cost that you will have to incur in terms of side effects, etc. And I think in that sense, I also see shared decision-making as a big promise that will lead to better choices.
Also because it includes other types of value, right?
Yes, if it is done right, it does. Yes, because it should start, there's the value to the patient is important if you're trying to think about what are the outcomes that we should measure, and I think a lot of work is being done in that respect by the International Consortium for Health Outcome Measurement, but also there are other groups who take information about what matters to patients and translate that into advice on which measures to use. But that's on the collective level, and you should also have that talk in the consultation room to really find out what matters to you.
Yeah. And how do you think that relates to also this discussion of this morning? What type of evidence do we need to say something about this promise of value-based healthcare, right? Because there's a lot of focus on measurements and hard data, but at the same time, this shared decision-making is, well, also very focused on stories between patients and providers, and how do these things relate? What should we focus on?
Yeah, well, that's, I think, on all of it. I think that the discussion of this morning, I think, illustrates the importance of choosing a design that is fit for purpose. And if it's about, if you try to study the claim that a pharmaceutical company makes about an expensive new drug, often a randomized controlled clinical trial is still the best way to look at that claim. But for other types of questions, you need other types of designs, and I think I'm a big fan of also using qualitative information, patient narratives, also to find out what matters to patients, because we do that a lot within our department, and it's really it brings you results that you wouldn't find if you only do quantitative research.
Yeah. Okay, thank you. Does anyone want to respond? Yeah? Oh, yeah, thank you.
So I was actually quite happy with your addition to the presentations, because I work at a national program which is about appropriate use. It's called Programma ZEG, Zorg, Evaluatie en Gepast Gebruik, Appropriate Use. So I was wondering if I would suggest to add a first step of checking whether the care we are talking about is based on evidence and the right evidence, and then checking does it add value to the patient and what does the patient want. What do you guys think? To first introduce the step, is this care based on appropriate evidence?
I think we try to do that, but there's not always evidence.
We know that there are 50% of everything what we are doing within care, there's no evidence. So if we still...
So you encourage the suggestion I made?
No, I think we don't have to wait until the other 50% are known, because at this moment we also know that we are not doing the right things for the patient. So I think at this moment we really have to look at what outcomes matter.
And if you really know those outcomes, then you yeah, then the next step is to look at the costs which are related to that outcome, because we really do not know that yet at this moment.
But
so I don't wait for the other 50% evidence.
But if you could know, so if you, it's a transition that takes time, but if you could add it to this, well, method, it's a new method to make sure that you get the evidence and then implement it in healthcare, in practice.
I think that's what the guidelines are all about doing,
well,
I think.
I have some interesting figures because there was an investigation on guidelines that were introduced in the last 2 years. There were almost 2,000 guidelines, and only 13% of them were based on moderate or a high level of evidence. So that states quite something, I guess.
Comes back to the thought of Trish.
Yeah, that's the question then, what is evidence, right? And what type of evidence do we base our decisions on? And I think that's very much related also to the guideline development question, which is very much focused on this evidence-based medicine type of thinking. But that doesn't mean that other types of evidence, I would say, are useless and shouldn't be incorporated in them. Because also in guidelines you have this professional expertise, but also the expertise of patients being incorporated in them. Yeah, those aren't RCT checkbox, but it is valuable to also take this expertise into account, I would say. But you are not convinced yet, but maybe.
I was asked to reflect regarding the provided incentives. In this case, also within a fee-for-service, there is not discouraged that you actually reduce all kinds of low-value care. If we try to change the provided incentives like we do in shared saving contract or in bundles, actually providers are getting accountable for their spending levels, and in that sense they have an incentive which is in line with reducing overuse. That's the same like the example of Maureen regarding reducing underuse. So, but when you change provider incentives, try to get them aligned with the overarching system goals you have, in your case, reducing low-value care. So also there, I think there is a link between how we pay for healthcare and how we get in your direction.
I'm going to snatch your mic. Diana, you also wanted to respond.
Yes. I would like to respond because I think if I understand you correctly, what you're saying is the things we offer to patients in a process of shared decision-making should, before we offer them, be carefully evaluated to decide whether or not they're actually effective and cost-effective. And I think on a high level of abstraction, I do agree with you that in an ideal world, you would not want patients to be given the choice to choose low-value care or even choose care that might be cause damage. But I think there are too many interventions out there to be able to evaluate all of them, let alone evaluate them in a way that would, meet these standards of evidence-based medicine, because often these interventions are not suitable to evaluate in that way. So I think we should work in both tracks, try to evaluate better what works and what works under which circumstances, but also accept that we can't do that for all the care that's being provided. So you should maybe look at which interventions offer the most risk to patients or cost a lot of money, and evaluate those first, and not try to fix the whole problem at once, because we can't do that.
Okay, yeah, Maureen. It is almost, then I come to Daphne. Yep.
Almost time?
Almost time, yeah. So
I wanted to react to Angelique's remark that we don't know the costs. If you allow me, I respectfully disagree. I think we know the costs of many interventions and treatment pathways, and we at least have the methods there to calculate the costs. And we build a lot of cost-effectiveness models with a lifetime perspective to simulate treatment costs across the entire life course of a patient. So the means are there, and we should apply them more. And I think that value-based healthcare, in which we monitor health outcomes and monitor healthcare utilization and costs, could provide us also with input to stratify the patients in our model into groups who may respond differently or show different patterns of treatment and different costs, and might help us to improve our cost-effectiveness models by stratification and moving towards that patient-specific, personalized medicine approach, and trying to predict what works for whom in which circumstances. So the information gathered in value-based healthcare research should then be feedback again into cost-effectiveness evaluations to optimize those predictions, right?
And
so
to find out the cost per outcome, that's what you mentioned. We know the cost of treatment, but not the cost of the individual outcomes, only the cost per quality, which is the all bundled outcomes.
Yeah, but we shouldn't forget that if we allow all kinds of different elements of value to come into play and into the decision what is the right treatment for the right person, we may pay a price for that, and we need to be aware of that as well.
We have to finish.
It's a good thing that we can do this session after the break again, right? Because I think we are not done yet amongst ourselves. But I'm going to give the floor to you, Daphne.
Yeah, I think I kind of wanted to just reflect on what both of you guys said, is that obviously in an ideal world, I would have liked to sit in a consultation room and get different options and have the doctor give me evidence-based research based on the options I was given. But like I said before, I would have not been sitting here in the way I want to be sitting here if I had chosen the one evidence-based option that I was given. And I think there needs to be a level of acceptance of every stakeholder, so the patient, the doctor, and everyone involved, that there is just things that we don't know, which as a patient, let me tell you, it's horrible to get options given when they don't know what it means in the end or the risk you're taking. But I think it's a level of acceptance, and that doesn't mean that we just accept it and then we move on the same foot. It means that we accept it and look at what are the possibilities to see where we can improve. But yeah, that level of acceptance needs to come from every different party involved, and also especially the patient, which is, from patient perspective, it's super hard to hear that you're given an option, but no one can tell you what the risks are of that option or whatsoever. But if they would have only given me the options that they did know the risks or whatever, then, like I said, I wouldn't have been sitting here the way I want to be sitting here. So it should be a door of opportunity to not always have the evidence there, because otherwise it could put a stop to looking to further options.
Yeah. So embrace the unknown, actually. That's even maybe a step further than Trish was talking about this morning. So that's really, really interesting. And I think it's also part of the discussion throughout, right? So we don't know a lot about value-based healthcare and this promise. We try in different ways to tease out to know more, but the effects are misschien always will be partly unknown, but it doesn't mean that it has its promise. So I think it's a really nice wrap-up actually for the discussion. So thank you very much. So I also want to thank you for your attention, and I think it's time for lunch. So we have to wrap up, and I think, well, if we do such a symposium in 10 years' time again, when we are 50, then maybe there's a little bit more unknown, but we will surely have other unknowns. So we will be looking forward to that discussion. Thank you.